Good afternoon, everybody. I'm Lena Castellucci, and I am pleased to be co-chairing this year's 2020 Thrombosis Canada Educational Conference. On behalf of Thrombosis Canada, I'm happy to welcome you to today's education session that is entitled Current Evidence, Antithrombotic Therapy for Atrial Fibrillation with Coronary Artery Disease. It's my pleasure to introduce Dr. Sean Goodman, who is a staff cardiologist and associate head in the Division of Cardiology, Department of Medicine at St. Michael's Hospital, and based upon his long-standing interest in oral anticoagulation, including stroke prevention and atrial fibrillation, he helped to design and is an executive steering committee member of the Augustus trial. Dr. Goodman, I'll pass it over to you.
Great, Lena. Thank you very much, and appreciate everybody's time and attention during this challenging time. Indeed, this program that myself, and as I'll show you in a second, several others put together and have recently updated is entitled Current Evidence, Antithrombotic Therapy for Patients Who Have Both Atrial Fibrillation and Concomitant Coronary Artery Disease. I was a co-chair with several other colleagues, Dr. Robert Welsh, who's an interventional cardiologist at the University of Alberta, Dr. Mark Eisenberg, who is a professor of medicine at McGill University, and the academy lead is Dr. Jeff Habert, a primary care physician also affiliated with the University of Toronto. I won't read out all the details of our disclosures, but I in particular have many of them. So affiliations with both for-profit and not-for-profit organizations. And importantly, specifically as it relates to my disclosures, I work with all of the companies that make antithrombotic, i.e. anticoagulant and antiplatelet therapies. And I'll be covering the spectrum of those therapies and try to give you as balanced a perspective as possible. Specifically, in terms of disclosure of commercial support, this particular session has received support in the form of an unrestricted educational grant from the Bristol-Myers Squibb Pfizer Canada Alliance. Indeed, I will receive an honorarium for my from Thrombosis Canada for my presentation today. And BMS Pfizer Canada Alliance obviously benefits from the sale of one of the products that I'll be discussing, Edoxaban, which is a NOAC, a non-vitamin K oral anticoagulant. In terms of mitigating potential bias, the information presented in the CME program is based on recent information that we've tried to be explicit in terms of including only evidence-based, and I'll point out wherever I'm giving my own personal opinion. This CME program and its material is peer-reviewed, and all the recommendations involving clinical medicine are based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in this activity is in support or justification of patient care recommendations, conforms to the generally accepted standards. I'd like to go over the 4 learning objectives, and we're hopeful that after participating in this program, you as quote-unquote learners or participants will be able to feel comfortable with the assessment of evidence supporting the current clinical guidelines for management of antithrombotic therapy in patients who have coronary artery disease. We'll discuss the need for an optimal antithrombotic strategy for patients who have atrial fibrillation, who happen to have also coronary disease manifested as an acute coronary syndrome, and or as part of the management are undergoing percutaneous coronary intervention, PCI, stenting, ballooning in the coronary arteries. The other learning objective is to evaluate the impact of emerging data on the management of this specific patient population in routine clinical practice. And finally, we hope that you'll be able to determine the role of ASA, aspirin, in atrial fibrillation patients who develop an acute coronary syndrome and or who undergo percutaneous coronary intervention. Now, I always like to place all this newer evidence and clinical trial information and guidelines in the context of a clinical case of a patient that I looked after that I hope will resonate with you. So this is a 70-year-old woman who has a history of hypertension, of diabetes, and of paroxysmal atrial fibrillation. Her weight and her eGFR are listed there, as are her current medications, including Edoxaban 5 milligrams twice daily for stroke prevention in paroxysmal atrial fibrillation. So she presented to my hospital with a non-ST segment elevation myocardial infarction, and she was in rapid atrial fibrillation with a ventricular response rate of around 130 beats per minute. Within about 24 to 36 hours, she underwent coronary angiography by one of my colleagues. I'm a non-interventional cardiologist. That should have been one of my upfront disclosures. The cardiologist found, by putting dye in the coronary arteries, that there was a fairly tight 95% blockage or narrowing of the ostial, in other words, the origin, the takeoff of the right coronary artery. There was a stenosis just after the origin of the right coronary artery above the aortic valve in the aortic root. A second-generation drug-eluting stent was placed with zero residual stenosis. The patient's heart rate was controlled with first intravenous, followed by oral beta blockade. And although she had a history of paroxysms in the past of atrial fibrillation, she remained in atrial fibrillation during her hospital course. She underwent an echocardiogram that showed inferior wall, infroseptal wall, and infraapical hypokinesis. So she sustained a non-ST segment elevation myocardial infarction with a small amount of damage to her left ventricle, but with otherwise overall reasonably preserved left ventricular ejection fraction of 48%, reminding everybody that the normal is around 55 to 60%. So what I'd like to do now is to put you all to work, and we're going to pose a question to you in terms of what antithrombotic therapy, now that she's been in hospital for, let's say, 3 to 4 days and has received dual antiplatelet therapy for her acute coronary syndrome and her stent, ASA, and a P2Y12 receptor inhibitor, but also oral anticoagulation. So at around day 3 or 4, she's going to be discharged home. What therapy would you recommend that we utilize? So I'm going to encourage the participants to vote. Number one, it will be anonymous, so I or anybody else will not see your answer. So there's no reason to feel foolish. But more importantly, there really isn't necessarily a right or wrong answer. There'll be a preferred answer that I'll come back to later on. But really what I'm trying to say to you is you can't go wrong by taking a stab, taking a guess at what you think would be the most appropriate. You'll see that the first two options are so-called triple therapy, where we combine dual antiplatelet therapy with aspirin and a P2Y12 receptor inhibitor of choice, like clopidogrel, with either warfarin as an oral anticoagulant or a NOAC of choice. The bottom two, or the second following two options, drop ASA after a few days worth of therapy with either a warfarin or a NOAC-based stroke prevention approach. And then finally, you have an option of choosing none of the above, maybe some other combination or permutation that you might prefer. All right, so hopefully we'll get folks to vote on that and give us their particular choices.
Can I just interrupt for a second, Dr.
Sorry,
Goodman? This question should have A, B, C, D, E down the sides of each of them.
Okay.
And I think people don't know how to vote. So A from the top, A, B, C, D, E.
Okay, I apologize.
And that's not showing up there.
That didn't translate. Absolutely. No. So A through A, B, C, D, E. A through E here in terms of your choices.
And if you move to the next slide, you'll see if we've got any responses.
All right. I'm not sure if people are being shy or whether I've just messed up the voting. But what I can tell you is, because I've shown this case for the past sort of year and a half, is we typically get options B and D as the most commonly sort of subscribed to opportunities. In other words, about half of the group typically thinks about discharging the patient on a triple therapy combination. Let me just use my laser pointer here so you at least can follow along here. In other words, ASA or aspirin, a P2Y12 receptor inhibitor like clopidogrel, and a NOAC. Apologies, I know in the Q&A section that some folks are having some challenges seeing the question, and I apologize that we didn't get the opportunity to engage you. The other sort of 40 to 50% of people typically vote for option D, which I'm circling here, which is a P2Y12 receptor inhibitor and a NOAC as the preferred oral anticoagulant. In other words, dropping aspirin after a few days' time. And sometimes we get a smattering of responses in some of the other categories. Now, the reason that there isn't a single right or wrong answer in this case, and why we typically see a little bit of a spread in terms of the different combinations and permutations that people might choose to prescribe for this woman once she's discharged from hospital, is that we face a conundrum as clinical practitioners in terms of how do we approach a patient who has atrial fibrillation, but also has an acute coronary syndrome and has recently undergone percutaneous coronary intervention and stenting. So let me walk you through this diagram taken from an editorial by one of my friends and colleagues that I think captures very nicely in a pictorial way the challenge that we face. On the right-hand side, the blue shaded circle, here's my woman who has atrial fibrillation and is at increased risk for stroke. Now, we know from previous trials that stroke prevention in atrial fibrillation is best managed, or the risk is reduced, by using an oral anticoagulant instead of using antiplatelet therapy, either single or dual antiplatelet therapy. In fact, the McMaster group in Hamilton led a trial that was stopped prematurely because there was overwhelming benefit of stroke prevention in atrial fibrillation patients with vitamin K antagonism with warfarin compared to a dual antiplatelet strategy combining aspirin and clopidogrel. So clearly for stroke prevention, either aspirin, ASA by itself, or aspirin plus something like clopidogrel, a P2Y12 receptor inhibitor, is an inferior strategy for stroke prevention. On the right, on the left-hand side in the orange circle, again, the woman that I'm looking after, she's had an acute coronary syndrome. She had a very tight narrowing in the right coronary artery, and my colleague put in a drug-eluting stent, which of course opened up the blood flow, but particularly in the first sort of month's time, is at increased risk of clotting because it's a foreign body inside of the coronary artery. And so we know from earlier trials that a strategy of giving dual antiplatelet therapy, like aspirin and clopidogrel, for example, is superior to oral anticoagulation, at least with warfarin, in preventing clots from forming in the coronary tree after a drug-eluting stent has been placed. And so it's the intersection here of these two scenarios where we typically see, or at least in the last decade or so, a triple therapy combination where we've thrown the whole kitchen sink at patients. On the one hand, an oral anticoagulant to try to prevent stroke. On the other hand, dual antiplatelet therapy to try to prevent stent thrombosis and recurrent ischemic events. The challenge is, as is depicted here, when we combine all three antithrombotic therapies together, we dramatically increase the risk of bleeding, including major bleeding. And so this is the challenge that we face. And the other reason why we often don't see one particular straightforward answer in terms of what combination and permutation to use is highlighted by this editorial that I've modified for Canadian drugs availability and doses. But you can see from this editorial that the number of strategies that we could potentially envision giving or exploring in my acute coronary syndrome patient who has concomitant atrial fibrillation. The bottom line here is there's almost 1.7 million different combinations and permutations. And that's obviously way too many for us as practitioners to try to streamline. And we need to narrow this down a little bit with some more guidance as to what combinations and permutations we should use that on the one hand reduce the risk of stroke, reduce the risk of stent thrombosis or clots forming in the coronary tree, while at the same time minimizing the bleeding risk that goes hand in hand with the combination of these different antithrombotic therapies. Now, up to 2018, when this meta-analysis was published, and I'll share with you in a second, the Canadian Cardiovascular Society Guidelines came out with their most recent iteration of treating these particular patients. This is a summary of the 4 randomized trials at that point in time that had explored this particular clinical situation. In other words, atrial fibrillation patients who were undergoing PCI, percutaneous coronary intervention, and had a clinical indication for stroke prevention with the use of oral anticoagulation therapy. And what I've done is I've circled in green, unsurprisingly in these randomized studies, if you look at dual therapy, typically dropping one of the antiplatelets and continuing with a single antiplatelet together with an oral anticoagulant, compared to a triple therapy strategy, you can realize reductions in bleeding. In contrast, we always worry about, well, if we minimize the risk of bleeding by dropping one of the antiplatelet therapies, for example, do we place that patient at increased risk for stroke, for stent thrombosis, for myocardial infarction, etc.? The totality of the trials suggests not. The point estimates, which are the blue bubbles here, and the 95% confidence intervals, albeit fairly wide, all cross one, suggesting that the reduction that we can see in favor of a dual compared to a triple therapy strategy approach was at least not associated, obviously, with an increased risk of ischemic events. And so it's this kind of data from 4 randomized clinical trials that led to Canadian guideline recommendations around the management of atrial fibrillation patients who have concomitant coronary and/or peripheral arterial disease. And they basically take 3 different scenarios, depending on whether the patient is undergoing percutaneous coronary intervention or not, and/or what the risk features are for the individual. And the fine print suggests that we need some help from our interventional colleagues if they're going to put a stent, if they're going to undertake PCI, to comment on what the risk is from an angiographic or anatomic perspective. For example, did they need to put a lot of stents in? Did they need to open up a complete occlusion of the artery? Did the patient previously experience stent thrombosis? All of these are anatomic examples of an increased risk for stent thrombosis in a particular individual. But the guidelines also emphasize that we as clinicians have to also consider not only the angiographic or anatomic features, but clinical characteristics that put a patient at increased risk, for example, for stent thrombosis, like diabetes, like a recent acute coronary syndrome, like chronic kidney disease. And so we have to take into account all of these features in determining what the risk is of stent thrombosis or recurrent ischemic events in our patients. So in my patient's case, we look at the middle bar. My patient has an acute coronary syndrome, an ACS. They're undergoing PCI, and so this is a higher risk situation, and the guidelines recommend triple therapy, in other words, an oral anticoagulant together with ASA and clopidogrel. Now, interestingly, the guidelines suggest that the weight of the evidence is that when you're choosing an oral anticoagulant, that in general, and in particular in this situation, individuals should preferentially receive a NOAC, a non-vitamin K antagonist oral anticoagulant, over a vitamin K antagonism like warfarin. Now, if you read the fine print in the red box here, you'll see that the duration of triple therapy is left to the discretion of us as clinicians, the treating clinicians. It can be as little as 1 day around the ACS and the procedure, or triple therapy may be continued for up to, on average, a maximum of 6 months. And we'll come back to what would be the optimal time frame for continuing triple therapy, recognizing the increased bleeding risk that is attendant with the use of 3 therapies And as soon as possible, we want to drop a therapy. The guidelines are now recommending that we drop down from triple therapy to dual therapy out to at least 1 year's time with an oral anticoagulant. And the preference is that the P2Y12 receptor inhibitor be clopidogrel, because we have the most experience with that inside of clinical trials, and it has a better bleeding profile than the more potent P2Y12 receptor inhibitors, for example, like ticagrelor. Now, the guidelines also go over the 4 trial regimens. I didn't go over the details that I showed you in the meta-analysis on the previous slide. And so there's a variety of combinations and permutations of either warfarin, vitamin K antagonism, or the 2 trials that had examined NOAC use, Edoxaban with a reduced dose compared to the usual stroke prevention dosing that we're familiar with, a very low dose of 2.5 milligrams twice daily of Edoxaban, which has really never been studied to definitively prevent stroke in patients who have atrial fibrillation, and then the 2 accepted doses of dabigatran, 110 or 150 milligrams twice daily. And then just to finish out the picture, at 1 year's time, in the green boxes on the bottom, when the patient is remote from their stenting, they're remote from their acute coronary syndrome, and they have stable underlying coronary artery disease, the recommendation is that we drop all antiplatelet therapy, yes, even aspirin, ASA, and simply go with oral anticoagulation. This is, of course, the best stroke prevention therapy in atrial fibrillation, but it's an underappreciated fact that monotherapy with oral anticoagulation can also be a very effective secondary prevention therapy in patients who have stable coronary artery disease. In fact, there are some earlier trials that suggest post-heart attack that oral anticoagulation, for example, with warfarin, is just as good at preventing a second heart attack or dying from a heart attack in coronary artery disease patients as good old ASA or aspirin. Now, you might say, well, we've got a couple of NOACs, we've got a warfarin trial, we've got enough information now. Why should we undertake any additional trials? Again, this is circa around 2018. Well, we that helped to design one of the trials, the Augustus trial that I'll share with you next, felt that it was still not clear because there are different combinations and permutations of dosing. And some of the previous studies, albeit a good step forward, all had some limitations to them. And in particular, Edoxaban, which is one of the most commonly employed NOACs in atrial fibrillation patients, and also Edoxaban, which is the newest kid on the block, also an excellent NOAC that can be used preferentially over warfarin in atrial fibrillation patients. There was really no randomized clinical trial data with those 2 NOACs, at least in atrial fibrillation patients who theoretically required dual antiplatelet therapy because they had just undergone percutaneous coronary intervention and stenting. The other thing that none of the trials did, apart from the Augustus trial that I'll show you, none of the trials had examined the independent benefits and downsides of continuing ASA or aspirin. And so that's why in the Augustus trial, we uniquely attempted to address 2 hypotheses in patients who had atrial fibrillation and either an acute coronary syndrome or were undergoing elective percutaneous coronary intervention and therefore receiving a P2Y12 receptor inhibitor like clopidogrel. Number 1, we wanted to show that Edoxaban was at least as safe or non-inferior to vitamin K antagonism for the major primary outcome of major or clinically relevant non-major bleeding. And number 2, unique again to the Augustus trial, we wanted to demonstrate, or we hypothesized, that ASA or aspirin would be continuing it, would be inferior to placebo for bleeding. In other words, we would see more bleeding with aspirin. Now, neither of those 2 hypotheses, you could argue based on previous data, would be a rocket sort of science hypothesis. But again, there were no randomized trials looking at these 2 specific questions back actually in the mid-2000s, 2015, mid-2010s, when we designed the Augustus trial. So Augustus was the largest of the 4 trials with the NOACs compared to warfarin, and we took patients with atrial fibrillation, and we included patients with acute coronary syndrome or those who were undergoing elective percutaneous coronary intervention, and we randomized 4,600 of them in an open label fashion to receive either vitamin K antagonism, targeting to the usual INR between 2 or 3, or apixaban. Now, we debated about decreasing the dose of apixaban to try to reduce the bleeding risk, because we're obviously giving the patients P2Y12 receptor inhibitor therapy, and in some cases aspirin or ASA therapy. But unlike the other trial, the Pioneer trial, where they reduced the dose of rivaroxaban, we decided that the best way forward was to use the standard approach to stroke prevention, because after all, these are all atrial fibrillation patients at increased risk for stroke. And in terms of the comparison of apixaban versus warfarin, a large previous trial had demonstrated better stroke efficacy as well as better safety profile with this particular dosing regimen of apixaban. And so we gave 5 milligrams twice daily in those who were randomized to the apixaban arm, and only reduced the dose to 2.5 milligrams twice daily in those patients who met 2 or 3 of the 3 familiar ABC criteria. Just to remind you, A stands for age 80 years of age or older. B stands for body weight 60 kilograms or lower. And C stands for a creatinine that's elevated above 133 micromoles per liter. So only if patients had 2 or 3 of those ABC criteria, as per the standard dosing approach with apixaban, including inside of this trial, only then would we reduce the dose to 2.5 milligrams twice daily. And it turns out that just under 200 patients in the apixaban arm had 2 or 3 of those 3 ABC criteria. 8.5% when they were randomized to receive apixaban got the lower dose of 2.5 twice daily. Now, in addition to the open label randomization comparing apixaban and warfarin, we were very interested in the independent effects of either continuing aspirin for the next 6 months or discontinuing aspirin. And the best way to do that is a double-blind comparison where neither the clinicians looking after the patient nor the patient themselves know whether they're continuing on aspirin or getting an aspirin placebo. This is a look at the baseline characteristics. I won't go over the details, just to highlight a few things. First of all, about a third of the patient population were women. The age is much older than the average clinical trial, and that's because patients who have atrial fibrillation and coronary artery disease are typically much older. So the median age was 71 years. The P2Y12 receptor inhibitor was left, the choice of it was left to the discretion of the treating clinician. And you can see 93% of the time the patients received clopidogrel, with only a smattering of patients being on the more potent P2Y12 receptor inhibitors, ticagrelor and prasugrel. Now, another unique thing about the Augustus trial is listed under these 3 subgroups of the qualifying index event. And that is these 24% of patients who had an acute coronary syndrome but did not undergo percutaneous coronary intervention. All the other trials included PCI-managed patients, stented patients. But we thought that it would be important to include a subgroup of patients where we face the same conundrum. Somebody who has had an ACS, maybe they even underwent an angiogram, but their management doesn't include putting a balloon or a stent in the coronary artery. But medically managing these patients with ACS, well, they would typically receive a year's worth of dual antiplatelet therapy, and because they also have concomitant atrial fibrillation, we would like to give them an oral anticoagulant. So the same question arises, do we give triple therapy, at least for the next 6 months, or not? And so that's why we included this important subgroup. The remainder of the patients, 37%, qualified on the basis of having both an ACS and undergoing stenting as part of the initial management during hospitalization, and 39% had stable coronary disease, but their symptoms were unacceptable to them, or they didn't tolerate anti-ischemic, anti-anginal therapies, and so they underwent elective PCI. And then the last row that I will come back to again to focus on this, recognize that the clinicians had up to 14 days after the ACS and or the PCI to randomize patients into the trial. So they had to find a time when they were comfortable after a day or 2 or 3 or up to 14 days of having the patient having received triple therapy, because once they randomize the patients, they don't know in the double-blind schema whether the patient is being continued on aspirin or whether aspirin is effectively being dropped by the patients receiving an aspirin placebo. And so the median number of days was 6, with a range of 25% having it stopped within the first 1, 2, 3 days, and another 25% having it stopped somewhere between 10 and 14 days. But the sort of average or median, 50% of the population had about 6 days of triple therapy before they were randomized into this trial. Here's the primary outcome, the safety outcome of looking at time to first major or clinically relevant non-major bleeding. And you can see that in blue, the Edoxaban treated patients compared to in red, the vitamin K antagonism, the warfarin treated patients, there was clearly a reduction fairly early on and maintained over the course of the 6 months duration of this particular study. So this tells us, consistent with previous trial data of Edoxaban compared to warfarin, but not specifically previously in the setting of ACS and or PCI, that in patients, all of whom are receiving a P2Y12 receptor inhibitor like clopidogrel, and half of whom are continued on aspirin versus aspirin placebo, we can see that there is a significantly lower risk of major or clinically relevant non-major bleeding with Edoxaban compared to warfarin. This is a look at some of the individual components and also some other bleeding measures. And I hope you can appreciate that the blue bars, Edoxaban treated patients compared to the red bars with vitamin K antagonism, are all numerically, if not statistically significantly lower in favor of a better bleeding profile with Edoxaban compared to warfarin. Now, the aspirin versus aspirin placebo comparison, these results are not particularly surprising to you. Indeed, with the dotted green line, placebo-treated patients are much less likely to have a major or clinically relevant non-major bleed over the 6-month time frame compared to, in purple, good old ASA or aspirin being continued after the ACS and or PCI. But a couple of points here. Number one, even the placebo-treated group, almost 1 in 10 patients by 6 months' time had a major or clinically relevant non-major bleed. And so even dropping aspirin, reducing triple to dual therapy in this patient population, while it does lead to a better safety profile, doesn't solve the problem, of course, of having clinically significant bleeding. Point number 2 here is that continuing aspirin to try to prevent stent thrombosis or recurrent myocardial infarction does lead to about 1 in 6 or 1 in 7 patients by 6 months' time having a major or clinically relevant non-major bleeding episode. So this is not a trivial thing, and even though patients and sometimes we as clinicians sort of think, well, you know, how harmful can aspirin be? You know, it's an over-the-counter drug. It doesn't even have to be prescribed. Well, the bleeding risk, particularly on a backdrop of P2Y12 receptor inhibitor therapy like clopidogrel, on a backdrop of oral anticoagulation for stroke prevention, oral anticoagulation, the bleeding risk is not trivial with ASA. And here are the individual components, again, numerically, if not statistically significantly, in favor of the green bars, placebo aspirin, compared to the purple bars, aspirin itself, ASA itself. Now, because we have basically 4 arms in the trial, a 2x2 factorial, we can plot all 4 of these arms and see that as a patient, the arm that you would have liked to have been randomized to at the end of the day with the lowest major or clinically relevant non-major bleeding risk was this arm down here, the dotted blue arm. Those are individuals who received Apixiban instead of warfarin, who received a P2Y12 receptor inhibitor, as all the patients in these 4 arms did, but who didn't have aspirin continued because they received by randomization an aspirin placebo. They had the most favorable bleeding profile over the course of the 6-month time of the trial. Now, our study, just like the other studies, even though it was the largest, 4,600 patients or so, was not powered to look at secondary outcomes like death, like hospitalization, like stent thrombosis, like recurrent myocardial infarction, etc. But we did pre-specify that we would look at both the Apixiban and warfarin as well as the aspirin versus placebo comparisons in a secondary outcome, time to first any type of death or any type of hospitalization. And I can show you that regardless of the type of hospitalization, Apixiban was associated with a lower risk of hospitalization compared to vitamin K antagonism over a 6-month time frame. In contrast, there was no statistically significant difference between aspirin and aspirin placebo with respect to mortality or any type of hospitalization, whether it was cardiovascular related, whether it was bleeding related, or whatever reason led to recurrent hospitalization. Another important point on this slide is regardless of background treatment, basically 1 in 4 of these patients are back in the hospital by 180 days by 6 months' time. So this is a very elderly, comorbid patient population at very high risk for recurrent events. And again, we can plot all 4 arms, and albeit high event rates, the arm that did the best was the Apixiban plus aspirin placebo. Now, I mentioned importantly, we didn't power our study to look at anything really apart from major or clinically relevant non-major bleeding. And so we have to take some of these individual events in the tables with a little bit of grain of salt. We are underpowered to potentially detect important clinical differences. However, I've bolded 2 statistically significant reductions, one that I've shown you already. Apixiban was associated with less any type of hospitalization compared to vitamin K antagonism, but we chose the right dosing approach, I believe, of Apixiban because we saw a significantly lower risk of stroke even at 6 months' time with Apixiban compared to warfarin, consistent with previous large-scale clinical trial data outside of a PCI setting. In contrast, there were no statistically significant differences comparing aspirin to aspirin placebo, but I want you to focus on 3 numeric differences that I believe, while they're not statistically significantly different, I believe this is just a power issue, and if we had a large enough trial or had continued the duration of therapy longer, I'm convinced that these would have become statistically significant. But more importantly, I think that they're clinically significant to take note of. So myocardial infarction rates were numerically lower in the ASA 2.9% compared to 3.6% in the placebo aspirin group. Stent thrombosis risk was almost halved with the use of ASA compared to placebo, and urgent revascularization was also numerically lower. So there is a slight price to pay, at least in some individuals who were assigned the aspirin placebo. Yes, they had less bleeding, but there was an increased risk, albeit small in absolute terms, in terms of myocardial infarction, recurrent or need for urgent revascularization, or stent thrombosis. And so I can summarize Augustus, and then we'll talk about another recent trial to give you the whole picture. But in terms of Augustus conclusions, in patients with atrial fibrillation, recent ACS or PCI, treated with a P2Y12 receptor inhibitor, 93% of the time that was clopidogrel, as compared to regimens that included vitamin K antagonism with warfarin, ASA, aspirin, or both, Apixiban without ASA resulted in less bleeding, fewer hospitalizations, and no important significant differences in ischemic events over the course of 6 months' time. Now, let's come back to the question of how long should aspirin be continued. So we looked at the occurrence of stent thrombosis risk in the patient population, regardless of their background treatment, and consistent with other experiences in randomized clinical trials and observational studies, most of the stent thromboses occur in the early time frame, so in the first 30 days after the stent has been placed. Sorry, let me advance. Here is the aspirin versus aspirin placebo comparison, and you can see that while it's not statistically significantly different, because the sort of red and blue 95% confidence intervals overlap one another, there is a numeric reduction. I showed you this before in a tabular form, that aspirin does appear to confer a benefit compared to dropping aspirin in terms of reducing the risk for stent thrombosis. But the good news is that absolute difference is relatively modest. Now, how do we balance the benefits of, for example, continuing aspirin to reduce stent thrombosis, to reduce recurrent ischemic events, against the increased bleeding risk that was clearly demonstrated by continuing compared to dropping aspirin? Well, we've subsequently published an analysis that looks at, on the left-hand panel, the types of significant bleeding events that obviously we'd like patients to avoid. And on the right-hand panel, ischemic events, including stroke and death and stent thrombosis and MI, that we'd also like patients to hopefully avoid. On the left-hand panel, you can see that there's, unsurprisingly, by 30 days' time, and evident within the first sort of 7 to 10 days' time, there's more bleeding of any significance with aspirin compared to placebo. The difference in absolute terms is about a 1% absolute increased risk of these types of bleeding compared to placebo by 30 days' time. On the right-hand side, you can see that ischemic events, the curves are swapped. In other words, now we can see a benefit with continuing aspirin compared to in green, discontinuing aspirin or effectively taking an aspirin placebo. The absolute difference in favor of aspirin in reducing these types of ischemic events is again around a 1% absolute reduction. Now, if we reset the clock and reset the curves at 30 days' time and go out to 6 months' time, on the left-hand panel you see a very similar picture where aspirin confers about a 1% absolute increased risk of significant bleeding compared to in green placebo. In contrast, when we go from 30 days to 6 months' time, with respect to ischemic events, we don't see any advantages now with aspirin compared to placebo. And so, to summarize, aspirin caused more severe bleeding events, but led to fewer severe ischemic events than placebo in the first 30 days. But aspirin caused more bleeding and did not reduce ischemic events from day 30 to 6 months' time. So our conclusion is that there's an equal trade-off in terms of bleeding versus ischemic risk if you want to give equal balance to those composite measures in the first 30 days' time. But once you go beyond the 30-day time frame, there is just more bleeding that's seen with continuing aspirin compared to aspirin placebo without any apparent benefits to continuing aspirin beyond that time frame. As an aside, and in the interest of time, I won't show you the curves, but we saw that Edoxaban caused fewer ischemic and fewer bleeding events compared to warfarin, both in the first 30 days' time, and had similar or fewer ischemic and bleeding events from day 30 to 6 months' time. So clearly, consistently a better profile. Now, to round out the complete story, the randomized clinical trial data, Edoxaban, as I mentioned, the newest in the last couple of years available NOAC, had been studied compared to warfarin in a large trial and showed some benefits in stroke prevention with Edoxaban compared to warfarin. This is a NOAC that hadn't been studied in this particular AF and PCI setting. So they took a smaller number of patients than we did, 1,500 patients, and they randomized them to two strategies in blue, Edoxaban with the standard dosing, only reducing the dosing in those who had renal dysfunction, low body weight, or concomitant use of a potent drug-drug interaction P-glycoprotein inhibitors. And so Edoxaban, given in the standard dosing, was added to a P2Y12 receptor inhibitor, and 92% of the time that was clopidogrel. Aspirin was dropped within a median of about 45 hours in the blue arm. In red, you can see the standard triple therapy regimen, at least initially, of vitamin K antagonism with warfarin, a P2Y12 receptor inhibitor, again, commonly clopidogrel, and aspirin. And the duration of aspirin was at least a month in these patients and could go up to 12 months' time. And so their primary outcome, the familiar time to first major bleeding or clinically relevant non-major bleeding, was numerically in favor of the blue line here, Edoxaban, compared to the red line, the triple therapy regimen, suggesting that Edoxaban is at least as safe as, but it didn't quite meet statistical significance, so we can't be definitive and say that it is a safer alternative in this particular setting compared to warfarin. Sorry. The one downside to the arm that got Edoxaban and had aspirin dropped within the first kind of 45 to 48 hours time was there was an early numerical increase in ischemic events. And so although they didn't randomize aspirin and aspirin placebo like we did in Augustus, I think these findings are consistent with what we found in the randomized allocation in Augustus. In other words, there is going to be a small price to pay for some patients with respect to increase in ischemic events like recurrent myocardial infarction, like stent thrombosis, and even cardiovascular death in patients where aspirin is dropped in the early time window. Now, fast forward to the end of 2019, 2020, a number of updated meta-analyses have now consistently shown that there is obviously an advantage to using a NOAC compared to warfarin. It reduces a bleeding risk, and that a dual strategy of dropping typically something like aspirin compared to a triple therapy strategy can also, of course, reduce the risk of bleeding. But there is still some concern that there might be an increased risk of myocardial infarction and an increased risk for stent thrombosis. In absolute terms, it's small, but there may be some individuals where continuing aspirin beyond the first day or two or three, maybe up to a month's time, is still warranted. And this topic was nicely covered by Shamir Mehta from McMaster University. He wrote the editorial that accompanied in the New England Journal of Medicine our Augustus trial publication, and reminded us, based on the guidelines, one of which he led in Canada, that the guidelines mean that there is no one size fits all, that the clinical decision making needs to be individualized for each patient. And we have to balance three competing risks: the risk for cardioembolic stroke and the use of oral anticoagulation to minimize that stroke risk, the risk for coronary ischemic events like stent thrombosis and recurrent myocardial infarction, and we typically think about giving dual antiplatelet therapy, but want to minimize the duration of that because of the third competing risk. If we give all three therapies, we are increasing the patient's risk of bleeding. And of course, we need to look at the anatomic characteristics of the stenting procedure. We need to lean on the interventional cardiologist to inform on the risk of stent thrombosis. We need to look at the clinical characteristics. We need to look at the clinical setting. Is it an acute coronary syndrome setting? Is an elective stable CAD setting, etc. And as I mentioned, lean on the interventionalist to talk about the angiographic complexity. And he gives two extreme examples in the editorial. Those individuals who have a low risk of thrombotic events and or a high risk of bleeding, well, there you want to try to stop aspirin as soon as possible, maybe even the day after the procedure. At the other end of the spectrum, there may be individuals with a high-risk ACS or complex multivessel PCI where we might not want to stop aspirin a day or two or three after the procedure. We may want to continue it, for example, for up to 4 weeks' time. And so coming back and concluding, what did we do in, how did I manage my particular case that I put the question to you about, well, we as the clinicians voted for option B, which was a triple therapy regimen beyond the time of discharge. So we gave the patient ASA, a P2Y12 receptor inhibitor, and a NOAC. We essentially continued the Edoxaban 5 milligrams twice daily that the patient had already presented on, so that was pretty easy NOAC to choose. But as I've shown you, there is data to support any of the NOACs, preferentially over warfarin in this particular scenario. Clopidogrel was the most commonly employed P2Y12 receptor inhibitor in all of these trials, and so we gave 75 milligrams daily and intended to continue that all the way out to 1 year's time. Of course, the Edoxaban use would be indefinite for this stroke prevention situation. And then finally, we debated, do we drop aspirin a few days after the procedure, send her home without any ASA? Well, you'll recall that the tight narrowing was right at the opening of the right coronary artery. And so the interventional cardiologist was worried that there was a slightly higher risk anatomically for recurrent ischemic events, including stent thrombosis. And it was felt that about a month's worth of ASA therapy should minimize that time period where the stent thrombosis risk was the higher. I just want to remind you that particularly in older individuals, that if you're going to use triple therapy, if you're going to include aspirin in the regimen, think about protecting the gut, at least for a period of time. In this case, we're intending to give it all the way out to 1 year's time, even though clopidogrel is less likely to cause gastrointestinal bleeding, upper GI bleeding than aspirin. But at least for 1 month, I think it would be prudent in this patient scenario to protect the gut with a proton pump inhibitor. So to come back to the original conundrum that we face, the overlapping of atrial fibrillation and antithrombotic therapy with oral anticoagulants and percutaneous coronary interventions, CAD setting, where we prefer to think about aspirin and a P2Y12 receptor inhibitor, I think we can conclude in general that the trials consistently show that any of the NOACs would be preferred over warfarin for stroke prevention and from the safety perspective when we're adding antiplatelet therapy to the mix in these coronary artery disease patients. So most typically, one will receive a patient will receive a P2Y12 receptor inhibitor like clopidogrel, and then we want to minimize the bleeding risk, and the best way to do that is to shorten up the duration of ASA, of aspirin, and this may again have to be individualized in terms of what the duration might be. So I am going to stop sharing my screen here and encourage you now to utilize the Q&A function. I hope that was of value to you, and would now again encourage you to ask questions. Thanks very much for your attention.
Many thanks for that great presentation, Dr. Goodman. I would like to start with a question from one of our Thrombosis Canada faculty, Dr. Alan Bell. So his question is, why when considering bleeding endpoints do we use a 30-day benchmark rather than earlier or later? If you can give us a comment on that.
Yeah. Great question, as always. Alan, thank you so much. And I'll just point out that Alan is one of the Canadian Cardiovascular Society panel members for one of the guidelines, the antiplatelet guidelines that I referred to. So he's an expert and always appropriately puts me on the spot with a tough to answer question. He's absolutely right. The 30-day sort of cutoff that we did for that landmark analysis to try to look at the balance of benefit and risk as it relates to bleeding and reducing recurrent ischemic events, it's a very arbitrary time window, including when we looked at the stent thrombosis. It's true that if we had looked at an earlier time frame, as he was outlining in his question in the Q&A section, 5 days or 15 days, we probably would see a sort of similar picture. Of course, we are underpowered, and so we arbitrarily also sort of looked out to that non-magical 30-day time window or 28-day time window, just so that we can have a little bit greater confidence about the number of events that are occurring, because even if there are clinically important differences, they may not even be visually apparent on a Kaplan-Meier linear curve sort of splitting apart when you look at such an early time frame like 5 days. But he's absolutely right that the guidelines recommend somewhere between that 1 and 30-day time frame in particularly high-risk patients for the continuation, but it is a very arbitrary time window. And so, you know, if a patient was at particularly high bleeding risk, but you felt that the patient needed more than 2 or 3 or 4 days worth of aspirin therapy, you could very reasonably say, I'm going to go to 14 days instead of, you know, 30 days time.
That's great. Thank you, Dr. Goodwin. Another question that I have, and is similarly echoed by one of our participants, when you approach a patient and you're choosing a direct oral anticoagulant or a non-vitamin K oral anticoagulant, personally in our institution, I've seen a lot of cardiologists use a reduced dose rivaroxaban of 15 milligrams once a day, despite not meeting criteria for that reduced dose. So, for example, they have normal renal function with a creatinine clearance above 50. So just wondering if you can comment on choice of DOAC and how you approach that.
Yeah, great question. So I was actually on the steering committee for the Rocket AF trial, where we looked at garden variety atrial fibrillation patients. If they had coronary disease, it was stable. So not the PCI or recent ACS PCI scenario. And we indeed, as you pointed out, demonstrated that the 20 milligram once daily dosing, and by the way, in the trial, we always had the patient take rivaroxaban with food. It doesn't have to be a major meal, but unique to rivaroxaban amongst the NOACs. None of the other NOACs seem to share this property, but the ability to give once a day dosing in stroke prevention is predicated on the sort of extended release effect by delaying the absorption somewhat by taking rivaroxaban with a meal. And I just want to point that out because people forget when they're instructing patients that's how we can give rivaroxaban once a day. It has to be taken with food. And we only in that Rocket AF trial, so we showed that it was at least as good, if not even a little bit better in stroke prevention than warfarin. And as you pointed out, we only dropped down to 15 milligrams when the EGFR, or more formally the creatinine clearance, was below 50. At that time, it was 30 to 50 essentially. Interestingly, the Pioneer AF trial in PCI setting, I kind of glossed over it. It was the first trial, but they did use a reduced dose. They used 15 milligrams and reduced it to 10 milligrams if the creatinine clearance was between, let's say, 30 and 50. So I would argue that if the patient hasn't had a recent PCI, and in which case 15 milligrams was the dose that was used in the trial, and they don't have an EGFR creatinine clearance below 50, I don't think that we should be using 15 milligrams. There isn't a definitive stroke prevention trial, at least in North American patients, I would argue, with that particular dosing. Now, some would say that the J-Rocket trial, J standing for Japan, which was a trial that went as a sort of companion in terms of the general Rocket trial, the Japanese investigators, they used a 15 milligram dose for stroke prevention and dropped down to 10 outside of a PCI or ACS setting. And they showed that there was less stroke and systemic embolism with that dosing of Riva. But those are on average much lower body weight individuals. So I would say for North American patients, we shouldn't be using lower than stroke prevention established dosing regimens of rivaroxaban.
Okay, and would you apply that to the rivaroxaban 2.5 milligram dose as well from Pioneer?
Yeah. So, you know, I know that they studied that dose and it's listed in the guidelines, and I showed it briefly because they studied that. But I'm really not comfortable with that dosing regimen for atrial fibrillation patients. Of course, since that trial, we know that from the COMPASS study, rivaroxaban 2.5 milligrams twice daily added to aspirin is a fantastic strategy compared to aspirin by itself for secondary prevention in stable atherosclerotic cardiovascular disease patients who have coronary disease, patients who have cerebrovascular disease, patients who have lower extremity peripheral arterial disease. So it's a great therapy, but they excluded patients who had atrial fibrillation or had a need for the stroke prevention dosing regimen. So I think that 2.5 milligrams of Riva is not a dose that we should be employing in atrial fibrillation setting. And similarly, the story around Edoxaban as an example, and I understand clinicians, we typically, go with the lowest dose, minimize the bleeding risk, but I would say we've got good randomized clinical trial data and a regimen that we should not be dropping down the dose of Edoxaban to 2.5 twice daily unless they meet 2 of the 3 ABC criteria. Great question. Thank you.
That's great. Thank you. Another question from our participants is if you can comment on patients who undergo surgical intervention or revascularization with CABG and whether or not this strategy would apply.
Right. So those patients were typically excluded from the trials. In fact, all the trials except for Augustus looked at patients who are undergoing PCI. And so we really don't have information in the atrial fibrillation setting and recent CABG to be definitive about, one oral anticoagulant versus another. And then, of course, the surgeons understandably usually want to continue some form of antiplatelet therapy after coronary bypass grafting has been undertaken. Now, the COMPASS trial, coming back to a non-atrial fibrillation population, the COMPASS trial did look at a large subgroup, over 1,000 patients who had a recent CABG trial. And although it's a subgroup and they obviously weren't powered to look at the treatment effect, they saw a consistent reduction with Riva 2.5 added to aspirin compared to aspirin alone, compared to the overall trial and all the other subgroups as a secondary prevention therapy. So I would say if the patient doesn't have atrial fibrillation, then absolutely it would be reasonable to consider post-CABG, post-coronary bypass grafting, a 2.5 milligrams of rivaroxaban added to aspirin compared to aspirin alone. But we really don't have any randomized trial data with recent CABG patients to be able to be definitive about what to do in that situation.
Okay, thank you. And another question from our participants is if you can comment on whether or not the stent type matters in choosing your dual antiplatelet therapy and strategy moving forward, whether it's drug-eluting or bare metal.
Great question. So, of course, the original stents were all bare metal, and the drug-eluting stents that have been developed over the past number of years, by their title, drug-eluting, contain some drugs that try to mitigate the natural process of sort of healing over the foreign metal body that's sitting in the coronary artery that can lead to restenosis, to re-narrowing of the artery. But the earlier generation drug-eluting stents, while more successful than bare metal stents at preventing restenosis, actually were associated with an increased risk of stent thrombosis because some areas of the drug-eluting stents were never sort of re-endothelializing. In other words, the natural healing of the body wasn't covering over parts of those stents, and some of those stents weren't properly expanded. A variety of reasons where there was an increased risk. The good news is that we're only interventional cardiologists in Canada across the board now, if they're using drug-eluting stents, are only using second and third generation, much newer drug-eluting stents, which are now actually safer than bare metal stents in terms of the risk of stent thrombosis. And so I would say that even though the hangover of the earlier days of drug-eluting stents is a longer duration of dual antiplatelet therapy, I would say now in Canada you can be very comfortable that if a drug-eluting stent was put in place, the patient's risk for stent thrombosis is now less than 1%, maybe even less than 0.5%, and actually is lower than a bare metal stent in terms of the risk. Yeah, great question.
Great, thank you. I think that concludes our questions for this point in time. So on behalf of Thrombosis Canada, I would like to thank all of our participants, and in particular, Dr. Goodman. This was a fantastic presentation, and thank you for your time and the great discussion following. I would ask our participants to ensure that they complete the evaluation, which is shown here on the screen, and you will also receive an email. This is important for members to receive credits for accreditation purposes. And I would ask you to visit our Thrombosis Canada website regularly for access to our new materials and our tools. And once again, this information will be archived on our conference website, and subsequent to the conference concluding, it will be available on the Thrombosis Canada website. So once again, many thanks to all of you for participating today. Have a good afternoon.
Thanks so much.